Ladies and gentlemen, welcome, and thank you for joining today's Protecting the Healthcare Worker in the Era of MERS, Bird Flu, and Other Emerging Contagious Diseases. Before we begin, there are a few technical details we would like to share. Please note that all participant lines will be muted for the duration of this event. You are welcome to submit written questions during the presentation, and these will be addressed during Q&A. To send a note, please use the Notes function on the lower right-hand side of your screen and address your questions to all moderators. In addition, you can adjust the presentation view on your screen by simultaneously clicking the Control and the plus or minus button on your keyboard. If you require technical assistance, please send a note to the ATT-CES operator via the Notes or call our help desk at 888-796-6118. With that, I'll turn the call over to Lynn White. Lynn, please go ahead.
Thank you. Welcome, everybody, to this special edition of the AMR eGrant Round. We're very pleased today to have Dr. Alex Isakov with us. Alex is a great friend of AMR. He is a professor of emergency medicine and the director of the section of pre-hospital and disaster medicine for the Department of Emergency Medicine at Emory. He's also the executive director for the Office of Critical Event Preparedness and Response at Emory. And you all may remember that Alex was a tremendous resource for us at AMR and also a great resource for those folks across the nation during the Ebola experience that we had a while back. We're very pleased to have him today. He's here to talk with us about emerging contagious diseases. So I'm going to be posting a couple of little notes to you all, and you should be ready to take down some URLs. I think we would love to have you complete a survey at the end of this presentation. It's very, very quick, and it'll be very helpful to us, so we appreciate that very much. So now, Alex, if you want to go ahead, thank you again for joining us.
No, thanks, Lynn. Thanks to you for inviting me to join you. Thanks also to Ed Racht and others who made this possible. Thanks also for that introduction. I am Alex Isakov. I'm from Emory University. The introduction was beautiful, but I think, foremost, what I am is an emergency medicine and EMS doc, and work with the EMS community, pretty much on a regular basis, and I get a chance to engage with people around the country. The last time I talked with you as a group at AMR, we were kind of in the throes of an Ebola outbreak in West Africa and trying to best prepare for travel to return to the United States with signs and symptoms. Times are a little bit different now, but risks are still out there, and I think collectively we believe it's important for paramedics, EMTs, and other healthcare workers to understand what the risks are, find ways to identify those risks, have a strategy to identify those risks, and then know what steps to take to protect themselves and others. I've got two bars I've got to try and meet today, maybe three. The first one is trying to make infection control somewhat interesting and exciting. That's a tall order. Two, probably an insurpassable bar is, trying to be as engaging as your friend and mine, Ed Racht, in making a presentation, online or otherwise. That's a tall bar. But I want to put this in context a little bit. Think about other infection control modules that you've participated in before, and ultimately I want to hear back from you all, is this more engaging than those? Because I think the content is important, and how it's delivered to you is important to keep your attention. So, with that, let's move forward in learning a little bit about risks that are posed to us in the out-of-hospital or in-hospital environment by contagious diseases and what steps we can take to protect ourselves. I have no conflicts to report. You've heard me say before, some people claim that's a failure of progression of career. For me, it's fairly easy. I do want to acknowledge, though, that in addition to the support AMR has provided by giving me this opportunity to reach out to you, the dissemination of this program is supported by the National Institute of Environmental Health Sciences Work Training Program. They're also the group that brings you HAZWOPER training, and they are supporting this infectious disease awareness program today. I'm pausing a couple seconds because I think it takes that long to upload the slides. So the objectives today are basically what I've said already. We're going to talk about some current infectious disease threats, that you need to be aware about in the out-of-hospital environment. And then we need to talk about a method to increase the likelihood of you identifying those risks, and then some strategies to protect you and others from exposure to those infectious bodily fluids and ultimately getting sick. Now, what is the issue here really? We face threats, every day. Whether that's concern about HIV, whether that's concern about hepatitis B or C. We implement standard precautions to prevent getting exposed to patients' bodily fluids. But then there are some other illnesses that require some additional protections and precautions that pose some additional risks. And those are ones that we need to pay a little bit more attention to. And maybe the more, the more exotic ones, the ones that do make the paper and maybe generate some concern, are those that are considered among, these novel influenza viruses, novel flu, or coronavirus like MERS or SARS, or what we faced with Ebola as an example, or what we, might even have faced in many of our communities with the measles. What Ebola taught us was that when you have a significant contagious disease outbreak in another part of the world, these problems, these issues that these serious contagious diseases are creating in other parts of the world are just one flight away from your community. That's what, among the many things we learned about Ebola virus disease. And here's a plug for containing these kind of illnesses, in other parts of the world before they can reach our shores here in the United States and elsewhere. There's a plug for that. But, one thing that Ebola virus disease outbreak in West Africa taught us was that these problems of trying to protect ourselves from serious contagious diseases are just a flight away. For those of you out there, I don't know if you had an opportunity to see these headlines, but if the CDC is concerned about the spread of a novel bird flu in China, the sudden spread of a novel bird flu, and they've gone to the trouble of promoting some travel warnings for those that would travel to China, I guess the question is, what does that mean for us here at home? Do these novel bird flus pose a risk for us here at home? Well, I'll make an argument that they do, and it's good to be aware of them, and it's good to have some strategies about how to protect ourselves. I didn't make those headlines up. They're real. Now, to get a little bit better understanding about bird flu risks, let's just take a couple minutes to remind ourselves what the risks for seasonal flu are. So you probably know, every winter the seasonal influenza virus goes running around our communities, making people sick. You might hear about influenza A and influenza B, different types of viruses that make humans sick. And then you'll also hear in the news, just like you did with that H7N9, you'll hear a lot of H's and N's thrown around, and it's just worth taking a moment to say, these are just surface proteins on the virus that basically help all of us classify these viruses and give them special names so that we know what we're talking about. So human influenza viruses like H1N1 and H3N2, they're the ones, the influenza type A, that are circulating around probably right now in your community and making people sick. And you know how influenza, this virus, is transmitted, and you know how it makes people feel. It's a respiratory illness. People are coughing and hacking. They're getting, sputum on their hands. They're shaking your hand. They're coughing droplets in your face. If you get sick after an exposure, which usually would happen about 1 to 4 days after you were exposed, you develop fevers, chills, muscle aches, headache. You'd feel like crap, and you'd probably want to take a few days off from work. And worst of all, and this is true for most all influenza viruses, before you got sick, you'd also be shedding virus for about a day, potentially making others sick around you. But that's seasonal flu. We deal with it, every season. And you know about this because you see these patients. Now, what you may not know is that there are some groups of people that are actually more likely to get more seriously ill if they get the flu. So if a person that's older than 65 gets the flu, or a young kid, or a pregnant woman, or somebody with chronic medical conditions like asthma or diabetes or congestive heart failure or neurological disorders, they're at risk for more serious illness. And so as a healthcare worker, not only don't you want to be exposed to somebody with influenza and get their infectious droplets in your eyes, nose, and mouth, but if you were to get sick, you don't want to spread it to others, because the patients you take care of, like kids and the elderly and pregnant women and people with chronic medical conditions, are potentially going to do, worse than you might as a person getting that disease. Now, here's my plug for getting a seasonal flu vaccine, which I know is controversial in many communities, but flu vaccines are safe. Flu vaccines actually have dead virus in them, so they can't give you the flu. And while they're not 100% effective, they're really your best way to prevent getting seasonal flu year to year. And that's important, not just to prevent you from getting sick, but to prevent you from making others, in your workplace sick, especially those that are immunocompromised and might not do well if they got the virus. Now, you might say, well, aren't there drugs I can take if I get the flu? And, of course, there are, like Tamiflu and Relenza, but there's never been any studies that showed that they actually reduce mortality, the odds of dying. They do shorten duration of illness. They can help prevent some complications of the flu, but mortality is about the same. And so, important then for you as paramedics and EMTs and other healthcare workers to know, how do you protect yourself from somebody who has a fever and muscle aches and is coughing and hacking? It's implementation of standard and droplet precautions. You don't want to those person's infectious droplets. So standard precautions include things like washing your hands, wearing gloves, making sure that your medical equipment is, wiped down one patient to the next. And the droplet precautions are largely a surgical mask that you use to prevent exposure of your nose and mouth to those droplets. Now, how does all this fit in with, these novel flu viruses that we mentioned before, the one that's spreading in China right now, this H7N9 virus? Well, the reason it's important is bird flus or flus that circulate in bird communities can sometimes make humans sick. And so examples of that are H7N9, the one that's circulating in China, and H5N1, one that's also been circulating all over Asia for over a decade. And then a lot of you are certainly been in EMS long enough to remember the pandemic flu of 2009, where there was a novel influenza virus. Nobody knew how sick it was going to make people, and there were special precautions that were needed in terms of taking care of patients that potentially had that novel flu, like not just wearing a surgical mask and some gloves, but also wearing a gown and some eye protection and even 95 respirator. And so the precautions for these novel influenza viruses are different if you're interacting with a patient that has them. And then you may also have heard of different viruses that kind of circulate in the pig or swine community, and they are, you'll see those sometimes in the news as variants of a type of virus. So if a pig virus can make a human sick, which it sometimes can do, they call that a variant virus, and that's the example there on your slide. So let's talk about this one that's in the news today, this H7N9. It's a type A influenza virus that makes birds sick, specifically chickens or in the poultry population. But this is one of those viruses that jump species. So most bird viruses just kind of keep to the bird population. But this one, if a human's exposed to infectious droplets, can make a human sick. And so the first human H7N9 infection with this bird flu was noticed in China in March of 2013. Since then, there have been about 1,200 cases. And there's a recent wave going on that's responsible for more than a third of those cases, 460 cases in the last few months. Now, the case fatality rate, meaning the number or percentage of people that die that get this illness in the first 4 waves of this H7N9 flu, was like 40%. 40% of people that got H7N9 bird died. That's a big deal, a high case fatality rate flu. Now, the good news is it's not easy for this bird flu virus to spread from human to human. So a human can get in contact with a sick bird, like in a bird market in China, and get a god-awful deathly illness. But the good news is, if they're sick, it's a little hard to spread it to another human from the sick human, which is good for us. So that means, at least for H7N9, right now there's no sustained human or community transmission, and there's no travel restrictions recommended, to China. Now, the CDC does say, if you're going to travel to China, stay away from sick birds, avoid wet markets like where they have live birds. Chicken there, and everybody will. Make sure it's fully cooked. Make sure you're washing your hands a lot. And here's the hook. When you come back to the United States, if you start developing a fever or cough or shortness of breath after that travel, tell your doctor about the travel. Well, that's important, right? Because that's going to help the doctor recognize that there's a problem. Or it's going to help you as an EMT and paramedic recognize that there's a problem. So someone has influenza-like illness. What's it? Fever, muscle aches and pains, cough, sputum production, and they've had recent travel to parts of China in the last 10 days. That should raise a flag that this patient may have more than just your average flu virus or your average respiratory virus, but might actually have a virus that's of greater significance because they recently traveled to China in the last 10 days since onset of illness. There's some other criteria, too. If you're a laboratorian in a BSL lab, or if for some reason you know you're in close contact with somebody who had H7N9, there's other criteria. But from most of us, it's simply let's ask the patient if they traveled overseas and put that together with that fever and respiratory illness. Now, H5N1, it's another novel bird flu. This one's been around, circulating for a lot longer. But again, a bird flu that when humans are exposed to it can make them very sick. It first emerged in 1997. It's actually the virus that got me interested in all this stuff with regards to trying to protect EMS and healthcare workers from serious contagious diseases. And here's an interesting thing, like where H7N9 was largely limited to the poultry market, so chickens in a coop, in this case, this virus was infecting ducks too, and ducks migrate, so they kind of go all over and they poop all over, and then kids or young adults or others get in this stuff, and they get sick. And so here's a kind of a global map, a little bit dated. It was last updated in 2014, about where this bird flu has caused human illness. And you can see there's a case in Canada, so the first and only case in America, but it demonstrates again that you can import these illnesses into your community and potentially put people at risk. Here's a slide that kind of shows the 854 H5N1 bird flu cases with 450 deaths, so over 50% case fatality rate, which is a really high case fatality rate. So humans that get this bird flu get real sick and don't do well. And so, how do we protect ourselves in healthcare or otherwise? Well, we got to prevent transmission of the illness. So we want to avoid sources of exposure, which are largely not endemic to the United States, which is good. But then we also want to apply infection control precautions if we were to recognize that, hey, this person with the fever and the cough actually has a travel history that raises concern about a flu. And if you go to the health department's recommendations now for how to protect yourself from these flus, like we mentioned before, it's not just a surgical mask and gloves, but it's all the stuff you do for standard precautions, plus contact, which means put on a gown in addition to gloves and have some dedicated medical equipment for evaluating the patient, and airborne, which I'll just remind you is putting on an N95 respirator, and also some eye protection. So this looks a lot like, if you recall, the H1N1 pandemic flu virus protections that taken in 2009. Now, in that case, that was a pretty contagious disease. The bird flus are not that contagious. Why all of these extra precautions? And the reason is because the case fatality rate from these bird flus is high, 40%, 50%, very lethal. And the CDC experts will tell you they're not exactly sure they know everything about these novel flu viruses. There haven't been that many human cases, and so they want a higher level of protection, which is important for all of us to know. Are there vaccines available? There are for H5N1, but they're not widely available. They're available for people that work with the stuff in the lab. Are there treatments? Not really. I mean, the antivirals like Tamiflu and Rolenda, they may or may not actually be helpful or effective against these viruses. Otherwise, it's just supportive therapy. Now, you mentioned H1N1 and the pandemic before, and that's really in great part why, the public health experts take an interest in these novel flus, these flus that are in birds that make humans ill, because flu viruses are always kind of changing their genetic code. And it might happen that just by, chance, and it's happened many times before, that the code makes it so that it's easier to transmit the illness from person to person. And you get a pandemic. What's a pandemic? A novel influenza virus for which there's very little human immunity. It makes people seriously sick, and the virus spreads efficiently from person to person. That's a pandemic influenza. And what's different about it, aside from, that it's kind of global, is that it infects a lot more people than the seasonal flu. So if you're having a bad flu season, I mean, the infectivity rate, like for seasonal flu, is 5 to 20%. A pandemic, it's like 15 to 40%. So people are getting infected. And you can see, like, the average U.S. deaths associated with seasonal flu, 36,000, 50,000. In the pandemic flu of 1918, 500,000 U.S. deaths and 50 to 100 million deaths worldwide. And there's no vaccine immediately available. And it's not just the sick and the old that are getting impacted by pandemic flus, but young and healthy people too. And so it's important for us to know how to protect ourselves with the appropriate, personal protective equipment and other controls that we might use to prevent exposure to those infectious diseases. There's, a few examples of pandemic flus that we saw in the last century, and I'd say this one that you recall in 2009 was really mild because it didn't make people that sick. It was a novel flu virus and was easily transmitted human to human. So we got to prevent transmission during pandemics too. So, for the population that's, good cough etiquette, cough into your elbow, wash your hands a lot, isolate suspected cases, keep them, away from others where they can infect them, and good infection control practice for us as healthcare workers. Other things like post-exposure prophylaxis and months later when a vaccine might become available, these things take time. Return to work criteria after you've had an illness. Guidance will come from public health authorities about those things, but those are the issues to consider around the flu. Novel coronavirus is the next threat for us in the community. I mean, this is, again, these are serious infectious diseases. SARS and MERS. Why talk about SARS at all? It was gone like in 2003, 2004, because a lot of what we learned in SARS we're going to use to be better prepared for a case of MERS that might come into our community. SARS being severe adult respiratory syndrome, MERS being Middle Eastern respiratory syndrome. So let's kind of refresh our memory a little bit about SARS. I'm a gray-haired old guy. I actually also lived through this in 2003. The good news is, in the United States, this really wasn't a big issue except keeping your eyes open. There were only 8 people in the U.S. that were impacted by, with SARS-like illness. But in Asia, in February 2003, it was a big epidemic, people getting sick, over 8,000 people that are reported to have been ill in 29 countries, and like 10% of them died. So a high case fatality rate again. This was last reported. Case was in China, which actually is a great, extra point here to say that those last 2 cases of SARS that were reported in China of April 2004 were actually among laboratorians that were doing experiments with it in a lab, which means that, it can get out in a lab and cause problems with laboratorians and potentially pose problems to us as emergency workers too. But look at the signs and symptoms of SARS. Fever to 104, headache, myalgias, cough, maybe some GI complaints. Looks a lot like your garden variety flu. And that's the problem with a lot of these more serious communicable diseases, is that until you can start to put it together with a travel history or the public health authorities alerted us that there's a problem out there, as healthcare workers, we're getting exposed to people all the time. Before we know there's a problem. And we're not. I mean, think about how you practice. I know how I practice in the ER, and I'm about as interested in this as any emergency medicine doc or EMS person could possibly be. And I know I cut corners on infection control when I see patients in the ER all the time. And I see it among my colleagues all the time, which is why we're at great risk for being exposed. So that's my pitch, to be a little bit more careful about your standard and transmission-based precautions. The case fatality rate for SARS was reported to be 6 to 10%, which is high. And it's the same, it's transmitted a lot by the same way. Close contact with respiratory secretions. People are coughing, they're bringing up sputum, they're getting it on their hands, they're getting it on tables and doorknobs, they're getting this infected sputum on pill bottles that you're reviewing when you're meeting a patient in their home. Unless you're wearing gloves, unless you're washing your hands, unless you're applying a surgical mask to the patient who's coughing, and you're taking precautions as well to be protected from those infectious droplets, you're at risk for contracting the illness. And let me underscore this point. In Hong Kong, of 138 secondary and tertiary cases, that means there was a primary case, somebody that had SARS, and of 138 secondary and tertiary cases, that means that were transmitted to others, over half were in healthcare workers. In Toronto, where this was also a big deal, over half of secondary and tertiary cases were among healthcare workers. We are at risk and need to be taking precautions to protect ourselves from infectious bodily fluids. The other hook on SARS is there was evidence of aerosol transmission. What does that mean? That means that if there was and we'll talk about this, an aerosol-producing procedure, then the less than 5 micron particles can kind of float around in the room, and you might inhale them on the other side of the room. And so the usual distance of 3 to 6 feet that would protect you from droplets becomes less effective when aerosols are produced. You know, aerosols can be airborne, travel across the room, go into air vents, and create a risk for exposure. I put up this basically this diagram to show you just, you know, what happens when healthcare workers aren't paying attention to their infection control practices. I mean, if you look, there was a patient that came from Asia where there was a SARS outbreak, came back to Toronto, and that person unfortunately died, but not before they made their son sick. Their son presented to an emergency department, and when they kind of followed the cases, in that emergency department, that patient infected 2 others that happened to be like in the same hall spot with him. He also infected 4 of his family members, and this cascaded on. You can see, you know, where ER visitors and ER patients and hospital staff and firefighters and EMS personnel, ER clerks and housekeepers were all impacted by this epidemic. So you had one single index case coming back to Toronto, and it was causing 224 cases and 38 deaths. Significant impact from a single person returning back from Toronto with SARS. Just checking. Am I still sharing with you guys?
Yeah, you are. And I was, you know, when you're talking about SARS, I do remember the sort of panic, maybe it wasn't panic, but the great concern with the EMS workers in Toronto. That was pretty amazing.
Absolutely. And in fact, there's a couple slides just to show you what the strain on the EMS community was in Toronto because of SARS. So before I get to that, so thanks for that plug. But when they looked back and they looked at why SARS, you know, became such an sort of an issue in emergency departments in Toronto, they kind of looked back at a number of factors. And, you know, and a lot of these factors I know are still true today in our emergency departments. The EDs are overcrowded. People are, you know, the patient with a cough and a fever, if there's no room, they get parked in a hall spot, or they're sitting in a waiting room for 4 hours waiting, you know, to get evaluated because they don't look like they're the most critically ill. They're in open observation areas, you know, with their cough and their sputum generation. And, of course, you know, a lot of these patients are wheezing, so they're getting an albuterol neb. And, you know, the aerosol that's being generated, bringing the nice medication down to your bronchioles where it's supposed to, you know, cause some dilation and prevent bronchospasm. Well, you know, the little coronavirus jumps on that and comes out when you exhale or you cough, and now you're generating aerosols in this way. Poor compliance with hand washing. True then, I say still true today, unrestricted access to visitors as well, all contributed to, you know, a major outbreak, an epidemic of SARS in the city of Toronto from a single index case that came from Asia. Here's another thing we learned during SARS, and actually you're seeing, you know, recommendations really amped up as a consequence of this and what we learned in the Ebola outbreak. Is there was among protected healthcare workers in PPE, they were recognizing, hey, they were developing SARS-like symptoms. That was concerning. So there was an investigation into that. CDC and Canada, Public Health Canada went and checked you know, what was going on in the ICU in Toronto. And what they found, among other things, was, you know, people were just taking their PPE off any way they like. There was no prescribed manner by which the PPE was being removed, which is a problem. Now, actually immediately after that, the first time you ever saw PPE donning and doffing instructions was in 2003. And they were very simple, like 4-step process. Now, the donning and doffing of PPE has been recognized as so important that you can go to this website, for example, and you can find donning and doffing of PPE ensembles, you know, with extensive checklists and recommendations to have a trained observer monitor the doffing of your PPE, because it's important to take your PPE off using a checklist with a monitor to protect yourselves from inadvertent exposure to those infectious droplets. One thing I'll note is that, the doffing checklist or the PPE doffing procedure, it has to fit the PPE ensemble you're wearing. So they're giving, in this slide as an example, they're giving, a few different PPE ensembles, each with its own doffing procedure. Whatever PPE ensemble you're using in your work environment, that doffing procedure's got to match. And so you've got to test them before you publish them, obviously. You heard me mention before what aerosol-producing procedures are, and you do a lot of them in the EMS community, and we do a lot of them in the ER too. You intubate patients. You suction their airway. You put them on CPAP or BiPAP. You give them an albuterol neb. Those are all aerosol-producing procedures. And so in a disease like SARS, or when we get to talking about, its cousin MERS here in just another minute, you're producing aerosols that are potentially infectious. You're increasing the likelihood that as a healthcare worker you're going to get exposed to an infectious droplet or particle that's being transmitted through the air. And so for these cases, if you can limit aerosol-producing procedures, that is ideal, and that's the reason why it's recommended that you decrease the use of aerosol-producing procedures when you can for managing these kind of patients, because you decrease the chance that they're generating infectious aerosols. You might remember back in 2009 during H1N1, initially CDC was saying anybody you suspected of having the novel flu, you need to have an N95 respirator, goggles, gloves, and a gown. And later on, they kind of backed off, and they said, well, you only really need that N95 respirator protection if you're doing an aerosol-producing procedure on these patients. You know that requiring an N95 respirator for every patient contact and that level of PPE ensemble is a burden and difficult to maintain. It's even difficult to maintain your supply chain to support that kind of activity. So point here being limiting the need for or limiting the implementation of aerosol-producing procedures can also decrease the likelihood of exposure to infectious particles. Here's what Lynn was mentioning about, how SARS was trying to bring Toronto's EMS community to their knees. They had 526 paramedics that required quarantine. That's a huge number. Why? Because they were recognized as having an unprotected exposure, either at a facility that had an ongoing SARS outbreak or an unprotected exposure to a patient. 526 paramedics. When I talk to communities about 526 paramedics being quarantined, they can't imagine how they'd continue to operate, and this was a huge strain on Toronto EMS. Now, with the Public Health Authority, they were able to mitigate that a bit with the Public Health Authority's input. They looked and they said, hey, look, it looks like SARS is only contagious when people are symptomatic. And you remember that from Ebola, too. They're only contagious when they're symptomatic. There's no evidence that the virus was transmitted from an asymptomatic individual. Most people are contagious in their second week of illness, or more contagious in the second week of illness than in the first. And so they implemented kind of a new strategy using what they learned about SARS to say, you can be quarantined, but you're going to come to work. You're going to be on work quarantine, just as an example. So SARS in Toronto came in 2 waves, and the first wave lasted 30 days. They had 234 medics on home quarantine. Look at the total number of quarantine days, like over 1,600. That's a huge drain on operations. And what they learned about SARS was that because if you were asymptomatic, you couldn't transmit it. They actually said, well, look, we'll start monitoring you at work. If you develop a fever or cough at work, then we're going to send you home. But you got to keep coming to work because we can't have all these medics on quarantine. That's kind of, the beginning of active medical monitoring during an outbreak. And that we saw this in the Ebola outbreak here, where we were in West Africa, we were trying to manage these patients here in the United States too. Anybody that had potential contact was being actively monitored for development of signs and symptoms. And the Toronto SARS experience was just a great example of how that was used to try and keep operations up and running. So for SARS, what's the infection control posture? Standard plus contact plus droplet plus airborne precautions. Limit aerosol-producing procedures. There's no vaccine. This is, what was required to protect you from SARS. The good news about SARS is it kind of just petered out. It just disappeared. It's not actively, currently being, it's not active in anywhere in the world right now except in a lab. But MERS is. So Middle Eastern Respiratory Syndrome is like the SARS cousin. It's another coronavirus. that causes human illness, and pretty serious human illness. First reported in Saudi Arabia in 2012. Most likely acquired from an animal. They're kind of, thinking it's exposure to camel sputum. And every case has been linked to some travel to the Arabian Peninsula. And since September 2012, there's been almost 2,000 cases, 684 deaths. That's a high case fatality rate. And you say, well, good thing, this is all in the Arabian Peninsula. Well, you'd be falsely reassured. There were actually 2 imports of MERS in the United States. You might remember it. They happened in May of 2014. These were healthcare workers working in healthcare facilities in the Arabian Peninsula, came back to the United States, one in Indiana, one in Florida. But the good news is people recognized the travel history. They isolated the individual. They got the appropriate testing, recognized that they had MERS. They both survived, and there were no secondary cases, meaning no one else got sick. Big, success story, because MERS is another one of these sort of, nebulous fever, cough, I'm short of breath, until you start getting so sick like you're going to die, with that 30% of these people, like 30% of the people that are infected with it do, and it's transmitted again with, contact with respiratory secretions. So, something you're all familiar with, trying to protect yourself from respiratory secretions. Here, have a look at this map. The Saudi Arabian Peninsula is not the only place that's been affected. Like I said, when you have, like we said at the very beginning of this talk, if you have an outbreak somewhere in the world, you can import cases elsewhere. Here's a nice map that kind of shows all the places that imported, a MERS case. And if you look over there, like all the way on the right side, you see the Republic of Korea, which is shaded a little bit more dark than most places on that map. You say, what in the world happened there? There was one case of MERS in a Korean that came back home, who developed signs and symptoms of illness and then started seeking care, at one hospital, and then got transferred to another hospital, and then sought care at a third hospital. And in the course of doing it, there were 185 secondary cases or secondary and tertiary cases of MERS and 35 deaths from one index case that came back to South Korea. So that case was imported in May of 2015, largest transmission cluster to date. Over 3,000 people are quarantined, 700 schools were closed, 185 cases, 35 deaths from one person. And if you ask the South Koreans why this huge transmission cluster was possible, they would tell you it's the same kind of thing that we saw with SARS in Toronto. Our hospitals are overcrowded. There's no good, hand hygiene or good respiratory precautions. Patients are in open wards with respiratory complaints. They're getting nebulized meds. Healthcare workers aren't meticulous about their infection control practices. There's a whole host of reasons why these epidemics, occur, and a lot of it has to do with failure to implement good infection control practices, which are, in great part, a lot of it's in our hands. So,
Dr. Ayukoff?
Yeah.
There has been a question on the chat line, and the question is, how effective is it to mask the patient rather than ourselves, or is that a false sense of security?
It's not a false sense of security. It's held out that it is effective to put a surgical mask on a coughing patient. It's not 100% effective. So as a healthcare worker interacting with that person that's coughing, you've got to wear the appropriate personal protective ensemble also. But yeah, it's absolutely been demonstrated to put a surgical mask on a coughing patient. You're limiting the chance that that patient can generate droplets, into the environment or into your eyes, nose, or mouth. And I make the point to say it's a surgical mask, not an N95 respirator that you're putting on the patient. Okay?
Thank you.
You're welcome. So MERS, it's good for you to recognize it. We'll talk about it, again in a minute. But in this case, signs and symptoms of a respiratory illness, fever, cough, sputum production, and travel in the last 14 days to the Arabian Peninsula. I know a lot of you out there have photographic memory, which is a heck of a lot better than what I got. But look at the list of countries that are in the Arabian Peninsula. I mean, I wouldn't be able to remember those without a cheat sheet. And so I am a proponent for EMS, as well as frontline healthcare workers screening for travel history in patients that present with illness. And so this is one that I think you have to have, on your radar screen as well, because MERS cases have been exported from the Arabian Peninsula into other communities, including the United States. What's your infection control posture if you recognize somebody? Obviously, you want to limit exposure to that person. You want to limit aerosol-producing procedures again, and you want to implement standard plus contact plus airborne precautions, which means that the N95 respirator as well as eye protection. There is no vaccine for MERS, and treatment's only supportive, so protecting us from getting that illness is most important. So review a little bit of novel coronaviruses. It's an acute respiratory illness, like everything that we've been talking about, transmitted in a healthcare setting, out of hospital or in hospital, prior to recognition of a problem or implementation of appropriate infection control procedures. Healthcare workers are, I'd say, largely or disproportionately affected. Their aerosol-producing procedures aggravate the problem. So does our, poor implementation of infection control procedures, and more attention to good infection control procedures can help protect us in our work environment. So that's getting into the sort of closing, theme of this presentation, which is we've talked about a number of potential threats that go beyond the threats that you protect yourselves from on a daily basis, like HIV, like hepatitis B or hepatitis C, like measles or tuberculosis. We can come back to a couple of those, but you need a way to recognize the threat so that you can take steps to protect yourself and others. And because all of these illnesses that we've talked about, like MERS, like novel influenza, are just one flight away from your community, and the others, like seasonal flu and meningitis and tuberculosis and HIV and hepatitis B and C, they're in your community on a daily basis, right? So we have to have strategies to recognize these risks and take steps to protect ourselves. And I don't know if you're familiar with this, but I'm going to try to make you familiar with the identify, isolate, and inform paradigm. So you may have heard this, identify, isolate, and inform. The idea is that you have some clues to identify people that pose a contagious disease risk, and you take steps to isolate them from you and from others until you can take appropriate measures to protect yourself, and then inform others to get some help. And so we're going to talk about that, not only in the context for which it was designed, which was Ebola virus disease, but trying to use this in the present day context as well. So look at this slide. This is the pictogram that comes from that website that I have listed on the bottom of the slide at CDC. Beautiful pictogram, identify, isolate, and inform, designed specifically for patients that would be returning from countries that had widespread Ebola virus disease transmission, so that you as healthcare workers can identify, oh, you've had recent travel to a country like Sierra Leone, Liberia, or Guinea when there was Ebola virus disease transmission there. There isn't any longer. Let's just make that clear. There is not any longer. But when there was, you'd say, oh, you've traveled to one of those countries. You have a fever and some headache and myalgias and vomiting and diarrhea. That's a problem. Let me isolate you, get the appropriate PPE on, and then inform others that, there's a risk here that we need to manage. Great paradigm, but I think goes beyond Ebola. The risk assessment is, what's the chance this patient in front of me has a serious contagious disease? And for any geographically constrained disease, meaning one that's happening in another part of the world but that could get off a plane in your neighborhood, like Ebola, the travel history is key. So with Ebola virus disease, the question was, have you traveled anywhere in the last 21 days that, had widespread Ebola transmission, and then do you have these signs and symptoms? And if you say yes to both, then you're a person under investigation, which means you need some special attention to make sure you don't have that illness, and so that those that are interacting with you can take the appropriate measures to protect themselves. Same thing for MERS. Have you traveled in the last 14 days to the Arabian Peninsula or a neighboring country, and do you have signs and symptoms of a febrile respiratory illness? And if that's true, then you are a PUI, or a person under investigation for MERS. You're taking steps to identify risk. And for these kind of diseases that are, endemic in other parts of the world, like Ebola was in West Africa at that time, and it can come back, or MERS in the Arabian Peninsula, or H7N9 in China, the travel history is key. Now the question is there any value in identify, isolate, and inform in this strategy if you're not trying to, if there's no emerging infection issue going on in other parts of the world, like H7N9 in China or MERS in the Arabian Peninsula? I say that there is. I say that identifying people that pose a risk to you of transmitting a contagious disease is valuable every day that you're working, because you can ask questions about, well, does this patient have a fever? Have they had unusual sweats? Are they coughing? Are they developing sputum? A follow-up to the question that was asked before, is there value in putting on a surgical mask on the patient? Yes, there is, if they can tolerate it. What if this patient's vomiting? Sometimes it's obvious, sometimes it's not. You come up on a patient and then, who has not had somebody vomit, all over their uniform? It happens. The more warning you have about the patient's condition before you're making close patient contact, the better. Measles is a great example of that. Measles is thankfully a vaccine-preventable disease, but let me describe to you how Christy Koenig, a colleague out in California, actually used the identify, isolate, and inform paradigm to help screen, for measles. Measles outbreak in 2014 saw 644 cases in 27 states. And you'd say, well, how is it possible that this vaccine-preventable disease is, where we have 644 cases in 27 states? Well, there's a lot of reasons. Some people don't get vaccinated. Others are, immigrating to the country that never had the opportunity to be vaccinated. And some people are immunocompromised, meaning their antibody immune system isn't working properly and the antibodies aren't being developed, and so you can have these issues. But this is a highly contagious disease, measles. It requires N95 respirator aerosol protection, and the way the patients present initially is they got a high fever and some muscle aches, but then you see they have these sort of bloodshot eyes, which you can see here, and if you look, you'll see these white spots in the sort of buccal mucosa lining in their cheek. That's the prodrome, and then you get this rash that starts on your face and spreads to your neck, trunk, arms, legs, feet. And so, you want to recognize these signs and symptoms, identify the issue, because if you're going to transport that patient, you don't want to transport this patient to the hall spot in the busy emergency department, or you don't want this patient to get triaged to the waiting room where they could be sitting with other immunocompromised patients and potentially making them sick. You want to identify this as an issue so that you can take the appropriate protection, aerosol protection required, and move this patient then when you're transporting them, for example, to a private room somewhere where they can't infect others. In fact, it should be an airborne infection isolation room, a negative pressure room, in quotation marks, to protect others, from the aerosol. So, this is another example of using the identify, isolate form for, more routine evaluation of patients. So that's the identify component. What's the isolate part? Well, meaning let's put the patient somewhere where they're not going to expose a bunch of other people to this illness that we suspect. So that means put them in an area with limited contact to others. In an emergency department, that means transporting them to a private room, not the hall spot, not the waiting room. When we're taking care of these people, we've got to implement good standard precautions, and we'll take 1 minute at the end of this just to review what I mean, because I've said that term many times in this standard precautions. These are the steps that we take to avoid contact with their bodily fluids. And then we've got to figure out what transmission-based precautions are required to prevent us from getting sick, which means, do we require a gown? Do we require eye protection? Do we require a mask or an N95 respirator to protect ourselves? And let's prevent others who aren't in the appropriate PPE ensemble from making patient contact. You know how this goes when you're responding to a call in the 911 system. 1 or 2 people can make patient contact, or, if you have an engine response and an ambulance response, it could be 8 people making patient contact. And for somebody that harbors a potentially serious contagious disease, you want to limit exposure. So that's part of what isolating the patient means, limiting the number of people that are having to make patient contact, and those that are making it, make sure they're taking the appropriate precautions to protect themselves from infectious bodily. And in addition to some of those strategies, and we talked about this already, placing a surgical mask on the coughing patient is valuable if they can tolerate it. You can protect yourself from droplets or protect yourself from close exposure to a coughing patient by keeping a 3 to 6 foot distance. That's what the CDC sort of defines as close contact. So if you can keep 3 to 6 feet while you're talking to somebody, then you could protect yourself from some of those larger infectious droplets that they're creating when they cough or they talk or they sneeze. And then, this is maybe more for our hospital colleagues in the ER than it is for us in the pre-hospital setting, but But, if they want to take this patient that you're suspecting has this more serious communicable disease and they want to triage him to the waiting room or to a hall spot, you got to try and, let them know, no, that's not what you want to do. You actually got to put them in a private room because of this, the fact that they're, having copious vomiting with fever or something else. And they may have to think about, well, where is this vomiting patient with copious diarrhea going to go to the bathroom? Are they going to use a public bathroom in the ER and potentially infect others? These are some considerations around isolating the patient. And here's an important note. We got to avoid delays in delivering essential care. I'm hoping that what we're sharing here today with all of you is going to make you more conscious of infectious disease risks and threats and sort of prepare you to take steps to protect yourself and others from being exposed to their infectious bodily fluids, whatever it is that they have. But we've got to have sort of our mindset right and our SOPs in place so that we can deliver the care that those patients need without getting paralyzed from fear, right? It's possible we get so worried that this patient has something more serious that we're not making patient contact, and the hypotensive tachycardic patient that may not end up having the serious infectious disease ends up dying for lack of care. We got to do everything we can to avoid that. Part of that's awareness, and part of that's developing SOPs to manage these patients and having the appropriate procedures and the appropriate, PPE ensembles available to care for patients when we need to. So we've talked about identify, isolate. What about inform? Inform is let's let others know that, hey, we're worried this patient might have a contagious disease. Don't make contact unless you're taking the appropriate precautions. So inform other responders. So, if EMD is getting some history that's raising concerns about a travel history and some febrile respiratory illness, let the first responders know. And if the first responders are there and they get that history, let the responding ambulance transport agency know. Let's inform people around us about, the risks that we're concerned about so they can take steps to protect themselves. Let the supervisory personnel know, too, so they can kind of help think through the next steps for patient transport and maybe, get to the right destination hospital. And this is true across all of healthcare. If we're really worried about a serious contagious disease, then let's get our, infection control officer on the line, or for the right indications, let's call that 1-800 public health number and let them know that then, those authorities can follow up on. I promised you in the last couple minutes I'd do a quick infection control review, and so here it comes, not to belabor these points. But there's a couple points I do want to make. One, when we think about infection control, and we've talked about it a lot, we think about PPE. Get me the right PPE and I'll be protected. But actually, if you look at, people that study infection control, PPE or safety equipment, it's kind of the last, it's your last line of defense. There are other things that we do, like environmental and engineering controls, policies that we put in place, work practices that we exercise that actually are probably more protective than actually that protective, ensemble, that PPE that we wear. But I got to have it all. I'm just here to say that, probably because those environmental and engineering controls, they're not even things that you think about. If they're protecting us from exposure to infectious bodily fluid droplets, they're probably more effective than we could wear. But you got to have all these things in place: the environmental controls, the admin policies and work practices, the safety equipment, or the PPE to protect us from exposure to infectious droplets. And a lot of these are built into what we kept referring to as standard precautions. Hand washing, it's a work practice, a procedure. The gloves we wear, it's PPE. The mask, eye protection, face shield, PPE. Gown, PPE. Cleaning patient care equipment, that's a policy and a procedure. Environmental controls, like having like an air isolation or airborne infection isolation room is an environmental control. It's recirculating air to prevent concentration of infectious aerosols. All of these steps, environmental controls, work practices, and the PPE, important. The whole goal is keep ourselves protected from infectious bodily fluids. And here's one that's really in our hands, so to speak. I'll get beat up for that, attempt at a joke. We don't do a good job washing our hands. We got all kinds of excuses. The hand sanitizer dries out and cracks my hands. I can't find a sink or soap to save my life. The towel dispenser is always empty. I don't have access to an alcohol-based hand sanitizer. I'm too busy. All of these are excuses that have been used before for why we don't wash our hands. And, aside from getting vaccine for vaccine-preventable diseases, good hand washing is probably the next most effective way that we prevent exposure to serious communication. That's standard precaution. That's part of standard precautions. Transmission-based precautions, which you've heard of before, contact precautions, droplet precautions, airborne precautions. They're important because these smart guys, at CDC and the public health authorities, they recognized that we need more than standard precautions to prevent transmission of these illnesses. So, for example, a patient with methicillin-resistant Staph aureus or C. diff or cholera or some other bad diarrheal illness like norovirus, they need good contact precautions. What does that mean? It means all the standard precautions that we just talked about, plus wearing gloves, wearing a gown, having that patient in a private room if they're, in an ER or a hospital, having a dedicated equipment for that patient or meticulous down in between patient counters. That's important. I'll challenge you to think about the last time you actually had a gown or were given a gown to wear for a patient that had a bad diarrheal illness. Think about that because contact precautions demand that a gown is worn. What about droplet precautions? Well, this is where you need a surgical mask. So, the patient that you're worried might have, the child that you might worry has meningitis, that meningitis, Neisseria meningitis, requires droplet precautions. So that means what? At a minimum, gloves and a surgical mask to protect you from those infectious droplets. And if you don't have the surgical mask on, you're not wearing the gloves, and you're having an unprotected exposure, and you're increasing the risk that you could actually get meningitis from the patient that you're managing. Droplet precautions are also recommended for the flu, which we talked about, unless it's a novel flu, and for mumps, which actually in many parts of the country also is sort of having an outbreak. And that's true for even people that are vaccinated because the vaccine is such an old strain of mumps, like back from the 60s, that newer strains of mumps they think are maybe what's causing some of these outbreaks in close communities like colleges and universities and nursing homes and other close communities. Airborne precautions require an N95 respirator, NIOSH certified and fit tested, to protect you from what? Commonly tuberculosis or the measles or a bad case of chickenpox or varicella. In our own community, the incidence of tuberculosis was so high at some of our homeless shelters that the recommendation from public health was for a responding EMS agency to wear an N95 respirator when they're just going into a shelter to go, make patient contact because the incidence of tuberculosis in the community. So that's a reminder of transmission-based precautions, contact, droplet, airborne, and what's required to protect yourselves. Here's a closing note. There are a number of standards out there that I know AMR is meticulous about adhering to. General duty clause, which says that the employer has to keep the area free of recognized hazards. Bloodborne pathogen standard, which requires protection for workers from blood or other potentially infected materials. The PPE standard that says you've got to be able to conduct a hazard assessment in your workplace and select an appropriate PPE. Or the respiratory protection standard that says, for example, that you need to be fit tested the 95 respirator to work, in the healthcare environment. All these standards are in place to protect us as healthcare workers, and a lot of the strategies that we talked about here in this last hour contribute to that, recognizing risks, taking steps to avoid keeping ourselves healthy, not allowing ourselves to get sick. And together, as a group of healthcare workers, as a workforce, and those that are employing us, we got to, work to ensure that these standards are upheld. So here's a closing slide, important themes. I think this identify, isolate, and inform sort of strategy is a great way to recognize hazards and risks in our work environment, to isolate that individual and prevent unprotected exposures, let others know that something's going on so that they can take steps to protect themselves too. We need to be vigilant for contagious diseases. Whether we're thinking about H7N9 in China, MERS in the Arabian Peninsula, the next widespread Ebola disease outbreak, or something closer to home like tuberculosis, meningitis, norovirus, C. diff, MRSA, we need to be vigilant for these contagious diseases and do what we need to do to prevent exposure to these infectious bodily fluids. We do that through implementation of good infection control practices, communicating the risk to others and say, hey, this guy's throwing up and having a lot of diarrhea. let's implement our standard precautions to include whatever it takes to prevent exposure to their droplets: gloves, a gown, maybe eye protection, maybe a mask if there's real risk of splash and getting infectious bodily fluids into your eyes, nose, or mouth. We've got to make sure we have our head around this so we're not delaying necessary emergent care for those that need it. Because, many patients that we see, while they may have signs and symptoms or maybe even a concerning travel history, will end up not having a serious contagious disease. I'll use an example, a case from my own memory: hypotensive, tachycardic, vomiting and bloody diarrhea, recent travel to Liberia in the context of a widespread Ebola outbreak there. There was, that patient got managed in our emergency department, but what he ended up having was a malaria, not a contagious disease. I was grateful that we were able to address that patient's, unstable signs, because we had procedures in place to recognize the issue and to apply appropriate personal protective ensembles to care for that patient and not let them deteriorate further because we were paralyzed from fear. It's important to be aware of these standards that I identified in the last slide, so that, working together to protect ourselves from exposure to infectious bodily fluids. And with that, with what little time we have left, I'm happy to answer any questions. You can certainly email me questions as well. And I think Lynn White at the beginning of this made a plug to fill out, I swear, is a 2-minute survey. And the point of the 2-minute survey is to see how useful this is to place and see if we can't make any improvement, in the quality of instruction and education that's aimed at us in the EMS community and otherwise, aimed at us to help us identify infectious disease threats and take steps to protect it. So with that, again, thanks to Lynn, thanks to Ed, and all of you for tuning in and paying attention. I appreciate it. Thank you.
Thanks to you, Alex. This is a lot of information packed into an hour, but really good stuff. The URL for the survey that Alex mentioned is on the announcement, and we do have one question I'd like to squeeze in if we could, but I also wanted to say that we've recorded this presentation and will be available from me, and also I think we're going to try to put it into the LMS and associate some CME with it or CEU with it. So contact me, Lynn White, if you need information. It'd be great for you to show this to your crews. So our question is from William Reiner, and he's asking about the recent, 2 cases of H7N9 in Tennessee chicken houses. Are you at all aware of that, Dr. Isikoff?
I actually am, and this is important, and I'm glad the question was raised. So the strain of H7N9 that is in Tennessee chicken houses is different than the Asian strain of H7N9. So actually, if you read this stuff, authors will distinguish the Asian H7N9 outbreak in China, which is a bird flu that has been recognized to be able to make humans sick. The Asian strain of H7N9 in China has, demonstrated an ability to make humans sick, like over 1,200 of them. The strain of H7N9 that you're seeing in Tennessee chicken houses, as of last report that I saw, which was probably within the last couple days, is a different strain for sure, and it hasn't made any humans ill. Okay, so big distinction. The chicken house H7N9 in Tennessee has not been shown to make humans ill. But here's another thing that gives me the opportunity to describe, because when you read about these things in the paper, sometimes they'll say, a highly pathogenic bird flu or a low pathogenic, or low pathogenicity bird flu. And when they talk about pathogenicity in these bird flus, what they're talking about is how sick. So a high pathogenicity avian influenza makes birds really sick and kills flocks. A low pathogenicity avian influenza actually causes a real mild illness in chickens. And the problem with that is you can't tell if your chicken flock is sick with, the flu, right? But the short answer, too late for that, right? But the short answer is the Tennessee chicken flock outbreak is a different strain, and as of now, doesn't pose a threat to humans.
Okay, good to know.
Good to know, absolutely.
All right, well, I guess we're about I think we're just about at our limit, and don't really see anything else out there. Shannon, do you see any other questions? Or do you have anything?
I do not. I do not see any more questions.
Well, again, thank you so much, Dr. Isikoff. This was great. I learned a lot. And as I said, we'll make this presentation available for others who want to either share it with their crews or with other folks. So please let folks know this is going to be available. And thanks for joining us.
Hey, Alex, I think on behalf of all of us at AMR, you've been very good to us professionally. You've helped us tremendously nationwide, and we appreciate that probably more than you know, so thanks for that.
Well, thanks for your comments, Ed. I think it's a great collaboration. You guys are great partners and always a great audience.
All right. Well, thanks again, and thanks to all the audience for joining us. And we'll see you next time. Can't tell you when that'll be, but there'll be one.
We'll be serving Tennessee chicken soup.
Tennessee omelet. All right. Thanks, all. Bye.
Thank you for joining today's conference. The session has now concluded, and you may disconnect.